Um, well, thank you everybody for joining us today and welcome to our second session of our Learning Collaborative on enhancing the use of clinical preventive services for adults in public housing. Okay, and this is just a reminder to everybody in case you're joining us for the first time. The content of this learning collaborative is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA or the U.S. government. The mission of the National Center for Health in Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. So with us today, we have Dr. Kevin Lombardi, who is in the line. And then also we have with us Jumoke Oladipo. She is our communications and research analyst. So she will be also co-moderating with us today. So we're very excited to have her with us. And then myself, my name is Fida Pineda, and I am the TTA manager here at NCHPH. So this is just a reminder to everybody that your line is muted upon entry. Please make sure that you also engage in the chat if you have any questions or any feedback. You may also unmute your line. So throughout today's session, this is going to be a very didactic and interactive session. So we encourage you to unmute your line and also participate verbally throughout the questions that we're going to be having on the case studies. Please also raise your hand if you feel more comfortable. That way, you could raise your hand and then your line will also be unmuted. This meeting is also being recorded and the slides and the recording will be sent to you all after today's session. Okay, and I will pass it on to Dr. Kevin Lombardi to go over some of the remaining learning objectives.
So here are the learning objectives, and I'll summarize them. Through the vessel of case studies and our discussions, we are going to be picking apart every piece of the clinical interaction and looking at evidence-based practices, promising practices, your very roles as healthcare providers and mandated reporters, and ways to improve programs based on the literature and the data. So we are going to do this as a collective conversation and one that is modeled against the interdisciplinary group. Myself, you know me, I'm a physician and an epidemiologist, and I love the mandolin. There's two beauties right there. Aren't they lovely? Yeah, okay, they're my mandolins. And I will be the physician reviewing the case and heading the case. With us are our two other participants. We have Fide and Jumoke. Wave to the camera, guys. Show them where you are. Their two roles will be as followed. Actually, Fide, why don't you go ahead? You will be doing our program management. Tell us a little bit about that.
Yeah, so essentially, I would be helping throughout the case study that we're going to be doing because we're looking at a specific patient. So I will be trying to provide input on what resources would be available and how can that be organized within an organization, per se.
In Jumoke, we will be talking more about pathophysiology of the patient. And what is that for you? Tell them some more.
So looking more into the health-related resources and how that impacts the resources that they're able to, how their health impacts the resources that they have access to.
100%. And through this, we're going to be talking in two languages. We're going to be talking clinically, and we're going to be talking in program management and support. These are conversations that we have together in our interdisciplinary groups, and we'll be modeling that. In addition, I see our audience, and I know we have some CHWs in the field. Wendy, could you wait for the camera for us? We'll be pulling you in for CHW at one point, and For each of you, please consider your professional responsibility and the way that you serve others as your hat for this discussion as we discuss the details. So let's go right into Mrs. Well, let's see what my next slide is first before I get ahead of myself. Next slide, please. Okay. So during this learning collaborative, we are going to be following Mrs. Tiller. Mrs. Tiller is an archetype patient that I created based on thousands of different people I have met. She represents common constellations of symptoms and common constellations of social needs. You will see Mrs. Tiller tomorrow. You will see him next week. And we want to understand as much as possible about this older adult archetype and the ways that we can follow them through their clinical history and support them maximally. And we're going to do this in a structured way. Last visit, we saw and this is based on your feedback that you guys wanted more visuals and more contextualization. So FYI, we do read those. We started with the outpatient clinic. We saw the patient in the clinic. They were diagnosed with conditions, and we began to look at their social determinants of health and social screening information and think about resources. Now, next slide, please. Today, we are going to be following that patient to the home. That patient has been referred, and it's time for her community health worker to do a safety assessment and medication reconciliation and so forth. Through the rest of the collaborative, we will be following Mrs. Tiller through a part of her medical history that is very significant because she's going to fall and break her hip at one point. And there's going to be a hospital admission for that hip and some therapy as well. And then we're going to see her post-discharge visit. Through these stories, we will talk about the prevention, the programs, and the practices. Next slide, please. Now, this is just a reminder, and I'll quickly summarize the patient. And for you, Jim, okay, for this is your first time seeing Mrs. Tiller, and for those of you who are new additions to our team here, this is a 73-year-old woman she is a resident of public housing, and she has a very significant chronic medical history. You can see the conditions here, but the things that are of primary importance to us now in the context of an older adult and safety are her osteoporosis, her diabetes, hypertension, and what appears to be severe nutritional deficiency through her vitamin D deficiency and anemia. That's just what we know, Jamoke and others. So I'm very concerned about that as well. As a result, also, this patient takes a lot of medications. So there's a concern that she may not have as much control over that as possible, and that her medication organization and management process may be predisposing her to poor management. And what I mean is, this patient doesn't have her pills organized. As a result, even if she thinks she's being compliant, she's not actually being compliant to the therapy. And we can have all sorts of chronic disease issues that come from that. So that's the patient. Next slide, please. And we had her vitals as well from the visit. We can go past this. Essentially, her hypertension was elevated. And I wanted to take a moment and talk about hypertension in older adults because the condition is almost ubiquitous in certain patient populations over 65. And I can think of handfuls of patients in my primary care population of over 65 who did not have this condition or did not have a pre-existing condition that put them at risk for it. It's a regular part of your management of the health of older adults. It is a prominent part for many of them. And hypertension, we commonly associate it with the following things. It has systemic effects. Everything the blood is touching will be affected by hypertension. And I want you to, as I'm going through these, consider Mrs. Tiller and consider safety and prevention and what these conditions and the risk of them may portend for her. For her brain, we'll go through organ systems, stroke, confusion, headache, and disability. Now, I'll start with you, Jamoke. If we have a patient that is an older adult and is at risk of or experiencing things like risk of stroke, confusion, and headaches, when we think of safety, what comes to mind?
Minimizing fall risks. If she and making sure her medication is up to date and accessible, so she knows what she's supposed to take when. Because if she gets too confused, she'll forget to take it or take the wrong dosage of it. And then making sure there's someone on hand uh, to help her in case that she falls or gets disoriented and can't make an appointment, or something happens in the home and nobody's there.
100%. It's a cascade of risk that comes from this. And I'll ask you to remember that term, cascade of risk, because you heard it here first. No. So think of the brain. And that hypertension is being felt throughout the brain. It is causing swelling, inflammation, all of these slow and denatured thought processes and the connections within the brain. So, if we have an older adult that already has risks due to where she's living, due to her age, due to existing chronic medical diseases or conditions, and she's now experiencing headache due to hypertension, and she's experiencing the results of hypertension, she's going to fall. And it's a major, major issue. Hypertension related confusion is not standard throughout the day. It isn't just one place. If the patient's blood pressure spikes, she will experience a change in consciousness that is proportional to that. So we can have confusion that isn't just happening part of the day or isn't just happening throughout the day at a low baseline. At times, the patient could get very confused and make very unsafe decisions that are uncharacteristic of them. It's a huge and persistent issue, and it emphasizes the therapeutic goal with these patients, blood pressure management. And we do that on my end through the prescription and management, and for most of you, through that medication reconciliation, which is half of it, and it is often the low hanging fruit. I cannot tell you how many times that a patient like this I have had that has a very stubborn blood pressure, and the issue was the administration. Very common story. Very common story. And there are so I will say there are almost every organ is affected by hypertension, and every organ has a set of diseases that are exacerbated from this. Of note, chronic kidney disease and insulin insensitivity. Hypertension independently raises insulin sensitivity. If a patient comes to mind that has hypertension and type 2 diabetes and end-stage renal disease, that's a very common archetype of patient. It's because these conditions are so intertwined. They are woven like a fabric. Next slide, please. I will say there are a few things that that can take care of all of those at once, and medication reconciliation is one of them. And that's just why that's so important. Other than I'll put this to the crowd. Fide, we'll do the hands, or then this is yours. What are some ways that Mrs. Tiller's hypertension may increase her risk of injury?
All right, so we don't have any responses yet, but then again, you can always unmute your line, and then you can also provide your responses here to this question. But in my opinion, I think that just given everything that we were just talking about, how it may, oh, I think we have somebody. Oh, sorry. How we talked about all of like the different medications that she may be taking and her risks for other complications based on hypertension. This may impact like even like her thought process. So that just automatically increases her risk of maybe falling or not being able to see where she's walking or think properly on like what she may be doing on a day-to-day, like just on like daily tasks.
Mm-hmm. confusion, general confusion leading to falls.
Yes.
Absolutely broke down the process as the patient would experience it. And that's just one. Another one I'll throw out there is vasovagal. For a patient with this chronic disease and this hypertension, when she stands up from sitting down, she is going to experience a lowering of her level of consciousness. She's going to experience an increase of risk of fall. And it's really a question of the severity. It's not a question of if it's there or not. A healthy cardiovascular system will compensate for that. And for those who have compromises to that system for a variety of reasons, and in this patient, it's the chronic disease burden. She's going to be at risk of falls from standing up. She will experience a drop in blood pressure, and she will have an increased risk of fall. And remember those hip injuries, how dangerous they are for these patients. Did I see we have comments?
Yes.
Fide, could you
Yeah. So let me unmute the line for Rula Murray.
Yes.
Hopefully, yes. Hi. Sorry if I mispronounced your name. How do you?
No,
could you
it's
tell us
fine,
who you
Rula.
are?
Okay.
Could you tell us who you are and who you serve, please?
My name is Rula, and I work for the Family Medical Center, and I'm a CHW care coordinator.
Okay.
Awesome. It looks like we got the right person on the line then. First I'll ask you, do you see these patients? And then if you could tell us your answer.
I don't see patients. I usually outreach to them over the phone, and we talk to them. We see what kind of risks they have, and we give them tips and resources and help them with any issues they might be having. And then we do have a lot of elderly that, we do telehealth. They can't come in because they have issues with coming into the office. And usually the doctors prescribe, somebody going in like for physical therapy to their homes and teach them how to balance at home and see the way they're living there and what kind of things they can help them with at their house.
100%. 100%. The risk of fall with these patients is significant, not just because of the injury itself, but because of the risk of something called the precipitous decline. For a patient who is an older adult, has multiple comorbidities, they often experience a rapid decline in their level of general health and their level of independence preceding an injury like this, and it leads to massive decreases in quality of life. So if we can prevent something like that, we really do someone a service. So I thank you for joining us, and thank you for your service to your communities. And I will say, as far as I'm concerned, if you're talking to a patient over the phone and you're dealing with things like that and doing telemedicine, you are absolutely seeing patients. So thank you for seeing your patients.
Thank you.
Fide, could we go to the next slide?
Yep.
So just to briefly go over the social determinants of health questionnaire, we had some yeses here. Patient, we're concerned for nutrition, concerned for her transportation to the facility. Next slide. And we're concerned for her safety. We later find out that the patient's safety issue was her fear of falling at home, which sent out alarm bells, of course. Next slide. So Mrs. Tiller had a social determinants of health questionnaire, and this is where we ended. We know the following. She lives in a one-bedroom apartment. Her adult daughter and son both live with 20 miles of her home. The other two live in different areas of the country. She doesn't have a healthcare proxy or direct advance directive of any type. She's active at her local church and public housing support resident support group. And her daughter and neighbors often help her with the medication. And the next slide, Fide, is questions. I'm going to ask them here. And I'll pose this first to the two of you and the group. what is coming to the forefront of your mind when you think of this patient and these answers? What risks come to mind, and what red flags are up when you read this info? And I'll say that to see, because there are a number of things here. And I'll ask for hands, and if not, Jamoke, the question is yours.
Again, you can also just unmute your line if, yes.
Wendy, could you tell us who you are and who you serve and your thoughts?
Yes, I am a certified CHW. I work with Heartland Rural Health Network and the Florida CHW Coalition. And my thoughts on this are her daughter and neighbors all often help her with her medications. I think there's too many hens in the pot there. She really needs to have things set out by one person and controlled by one person. I would take her medications and make sure that they were sorted on a daily basis, put the time of day that she should take each one of them, because people may take their medications, but they could take them at all different hours of the day, which affects the, they have an up and down reaction to these medications because they're not steady. I'm concerned that she lives alone in a one-bedroom apartment. I would definitely want to go into the apartment, make sure there are no loose carpets on the floor. I would check what kind of foods she has in her cupboard. I would do a very in-home wellness check to see that, you know, she doesn't have throw rugs on the floor that she can trip over. I would make sure that she has the correct food for her diet. In this case, you know, she should definitely not be having sugar. She should definitely not be having salt. And you want to make sure that those canned goods and frozen goods are low in sodium, are low in carbohydrates. There are a lot of things this woman needs some help with, and I would make sure that I do regular visits to see that those the social determinants are all taken care of. That's what I have to say.
Well, I'll tell you, you really nailed it there, Wendy, because this is exactly what I was trying to get at here, is these complex patients with a lot of hands in the pot. And I appreciate the rigor of your response. And I have about 30 questions for you, but I'm going to bring it to one. And it's, I have a feeling you see a lot of patients like this with a lot of medication, and you said a lot of hands in the pot. Could you tell us again, or give us some insight on how you manage these situations when you're seeing patients?
I would have a primary caregiver who would take care of sorting out the medications, making sure that she's taking them at the right times. I would ask for help in other areas, such as perhaps doing some house cleaning or doing some cooking for her. But as far as medications are concerned, boy, they can really mess you up if you do it wrong. And I do have experience with it. I have experience with it not only as a CHW, but as a caregiver for 5 other people when, as they were on hospice. So
So you've seen this, is what you're
I've
saying.
actually seen this. My own mother, you could be talking about my own mother. So,
well, this is
yes.
a very common patient. It's a very common patient, and I appreciate the insight, Wendy. I'm going to bounce a question to Jamoke. Based on our CHW assessment, where do we need to go next?
Like Elizabeth and Wendy said, definitely setting up a physician that knows this case. And the fact that she says she has no advance directive It makes me question how often her daughter helps her. If her daughter can be made the directive if she's not able to make those choices for herself.
The advance directive is a big one, and healthcare proxy is a big one. If this patient were to fall and go to the hospital because of a hip injury, goes through the hospital, she's assigned a surgeon and physicians, and she goes into the ED, and then she's admitted to the hospital. So if she doesn't have a proxy or advance directive, that makes a lot of things more complicated. First of all, if this is, for example, if you consider a much older patient, 89, 90, or someone someone who is physically frail and may not want to go through the full rigor of resuscitation. If they don't have an advance directive, we do everything. And they will end up, in certain circumstances, I have personally served people who, because of that, had to be in the ICU in advanced care and would not have wanted that if they had it. They were the victim of not having an advance directive that says this. So this can be very tricky. Everyone should have an advance directive. If you are an adult, have one. I don't have one. I'm going to make one, Jim. Okay, I'm going to take my own advice on this. But I have had many conversations with colleagues about this who are in their 30s and have an advance directive, and you should too. I should too. So big thing there. And healthcare proxy. Wendy pointed out this when she said too many hands in the pot. Who am I talking to here? Let me tell you, I can't tell you how confusing it is and how much it delays care when you don't know who to talk to, because you end up doing this mission to piece together this person's social life to find out who's the person who's primarily responsible. And that's difficult. And if there is no one who's obvious, at times you can spend a lot of time chasing your tail, trying to get a consent and trying to get things done. It is a efficiency killer. So let me tell you, being able to open a medical record and seeing that these things are there, it relaxes you when you're doing an admission. So as far as location where we're going, what I hear from Wendy is that we need to see this patient's home, which is the next step. So next slide, please. And we did this. So after this, got ahead of myself. Okay, so Mrs. Tiller's provider refers her to social services. The patient's social screen, which we just saw, is reviewed by the social worker, who assigns a community health worker to visit her in her home. This is for a home visit. The physician prescribed this, and this was billed because it met patient needs. Anyway, the home safety is going to happen. The way that the CHW is going to do this is very specific. Next slide, please. Now, the CHW starts with a medication check in the patient's living room or kitchen. In this case, it's a kitchen. She has a table. The CHW goes in, does like a quick assessment as she's walking, but does not do the home assessment, hazard assessment yet. She sits down with the patient, and they start with medication reconciliation. This is what they find. And Jamoke, get ready. I'm going to have a question for you. Mrs. Tiller takes a total of 23 medications daily. This includes vitamins and supplements they're all prescribed by her physician. Same name on the bottle. The medication list that Mrs. Teller brings with her and was with her in the clinic is not up to date and omits new antihypertensives that she's been prescribed in the last year. The new stuff isn't on her list. She doesn't use a pill organizer. Her bottles, though, are neatly organized. And Mrs. Tiller is occasionally helped by her daughter and neighbors for her medications. She usually does it herself. And I'm going to start with you, Jamoke, and then I have a program management question for Tige. But thinking of the patient's chronic medical history and thinking of this situation here, what is coming to mind for you?
How easily she can confuse her medications. Because the bottles are there, but if she doesn't remember whether she took one today already, she might double a dose, or confuse one for another.
Mm. If I were to ask you now, I were to say the following: this patient is at times confused, and then ask you, "Are you surprised?" What would your
No,
answer be?
no,
Just based on that one fact, right?
yeah,
Just based on one fact. Now, she's got all the other medical conditions that also can predispose her for confusion. If you think of all of those different dynamics working at the same time, that's at times she could be very confused, disoriented, maybe at risk for falls. Maybe she would be likely to misplace something or to get confused as to where she were and to react in fear. That's when people trip. That's when people fall. That's when bad things happen. Is there anything, Wendy? Thank you, Jumoke. Wendy, what comes to mind for you? Do you have thoughts?
I'm very, very concerned about medication. I see that she has been prescribed antihypertensives, new antihypertensives. If she has her pills in the bottles and they're on the shelf, she probably has some old antihypertensives. And I know of a case that there were 3 different bottles of prescriptions that had different names. However, they treated the same condition, and the person was tripling the amount of medication she should take. And a
That
lot
is
of it,
horrible. That is
and a lot of
horrifying.
it was because of confusion. And the patient ended up in the hospital and on the respirator. And luckily, it was only short-lived, and they were able to clean out her system. And she ended up having home visits from a nursing, in-home nursing care. But this is a very, very real case for sure.
Yeah, and I'll tell you what, Wendy, when people in my seat screw up, people in your seat have to deal with it. And what I'll say to prescribers is do not set your patient up for failure. When there are multiple medications and complicated medications, and the patient's medication reconciliation has not been done appropriately, you really set a battlefield up for them. You set a battlefield up for them that almost predisposes to these things. Rebecca, could you tell us who you are and who you serve first, and your personal opinion of Wendy, and then what are your thoughts?
I don't know if Wendy wants to hear my personal opinion of her. But I am Rebecca Ibarra. I am with Heartland Rural Health Network and the Florida Community Health Worker Coalition. I am a certified community health worker in rural Florida. And as usual, I probably agree with like 95% of what Wendy said. And although her prescriptions are given to her by the same physician, one of the things I would check definitely is she getting them from the same pharmacy? Because most pharmacies today they'll ding you if you get one medication that does the same thing, or they are contraindicative of each other and things like that. But it only works if you're getting it from the same pharmacy. If you're getting one prescription from one pharmacy, one prescription from another pharmacy, it's not always going to ding. And so they can't contact the doctor and they can't say, hey, do we want to look at this again? It's all about continuation of care and coordination of care, especially when you have so many conditions. There's a lot of contraindications on medication, and that coordination of care it can make all the difference.
You brought up a lot of good points here. The pharmacy thing, I've got to be honest with you, I didn't even think about it. I didn't even think about it. And I can't imagine how many times I've done this to people. I can't imagine. Because I can tell you, with the usual patient that is a discharge from the hospital, there's usually a couple of pharmacies that are on their list. And it's not always easy to make sure that those things go to the same place if there's 2 or 3 prescribers. So very good point, very good patient safety point as well. I'll ask you another question. Is you gave us a really good pearl there with the pharmacy issue. I'm assuming that you see a lot of these patients too, the Miss Tiller archetypes. What are some more thoughts you have about medication safety and safety in these patients, if you have any?
I mean, the biggest thing when it comes to medication safety, and you can tell of where, some people think of this based on where they came in. I worked for the pharmacies for over a decade. And what it comes down to is getting your medication at the same place and hoping that your pharmacist is a good pharmacist. And I do see it. In fact, this past year, I had a client who was on warfarin. And for those of you who don't know, warfarin is a blood thinner. And she was very good at taking care of her medication. She was very good at her diet. She'd been on it, recovering from a stroke going on 10 years. She knew what she was doing. But for some reason, her medication was sent to another pharmacy and they filled it, and it was a different manufacturer. And since she saw that the pill was different, she assumed it was a different strength. And she ended up, instead of taking her 6 milligrams, she ended up taking 10 milligrams, ended up in the ER because she had some bleeding. And it took 2 hours of sitting in her home, going through all her documents, asking the exact same questions. Because I'm sure when she got to the ER, they asked, are you taking your warfarin correctly? Did you eat something you weren't supposed to eat? Et cetera, et cetera. She goes to her doctor. Her doctor is very good, saw her the next day after she got out of the hospital. I guarantee you it was the same questions. Are you taking your warfarin correctly? Did you eat something? And of course, she's saying, yes, I'm taking it correctly. Yes, I'm eating correctly. I didn't eat 20 avocados, things like that. And then I go in and I start the same questions. And it took about 2 hours because, something has changed. What has changed? I'm reading all her discharge papers, and she just makes a blasé comment about how Walgreens screwed up her prescription. Or they labeled her prescription wrong. And I was like, let me see these bottles. So I was able to do a pill ID, which is horrible on a very tiny phone and a very tiny pill, but I was able to do an identification on it. And sure enough, she was taking 2 5-milligram pills, but it took 2 hours to get there. How many doctors can sit with a patient for 2 hours? And then, of course, she's answering her doctors, no, I'm doing everything right. But it was that one little label from a different pharmacy, and she didn't get dinged because it was a different pharmacy.
Well, I'll tell you one thing, Rebecca. That story just made it very clear just how complex the responsibilities of CHW really are. That is incredible. And also how much more effective they are at some of these reconciliation tasks than the providers. And being able to sniff out those things and find those differences, that's a big patient safety win, Rebecca. That's a huge patient safety win. So congratulations and thank you for the comment. I'll ask Fide from a program management, patient education perspective. I'd like to add another layer here. So say Mrs. Tiller is Spanish speaking only. You're our Latino health expert. We did some talking earlier about patients and the differences and so forth and the complexities in different languages. Do you have anything to add to the conversation that we should take into mind when we have patients with that are non-English speakers?
Yes, absolutely. I think like the education part is very important, especially when it comes to the CHWs. And again, correct me if I'm wrong, but I think equipping the CHWs with the right resources and training that they may need to provide education and guiding the patient in Spanish, for an example. In this case, this is very important because the patient will need to understand all of the steps. Mrs. Tiller will need to understand all of the steps, all of the medications, like when does she need to take it? What are some of the precautions that she needs to take? She needs to be able to understand this in another language. And having the CHW that can help her communicate and avoid any confusion about all of her medications in Spanish. This is going to help prevent a lot of, the complications that could happen, just as the ones we discussed right now.
So when I reflect on what you've said, Fide, I think of certain patient situations that I see, and one of them is the provider or the family member doesn't speak English themselves, and the other and that's a major barrier itself. And as you're saying this, I'm thinking about our Spanish language providers. Rebecca, remind me if I'm correct, but are you a Spanish language provider as well?
Yes, I am a Spanish language provider.
Do you have any
And
thoughts for us on providing instructions to patient in Spanish that we might garner from your experience?
so at a 73-year-old Hispanic female, I would be, one of the things that I would look at is what country is she from? Because that would determine what dialect I need to speak with her or try and communicate with her. And my other concern is that at 73 years old from certain countries and she being female, at most, if she was lucky, she had a 5th grade education in her home language. And so would you give a complicated medical information to a 5th grader so that they can manage it themselves and hope that they could read the information? Automatically, most of us would say no. But when we're looking at these, especially older Hispanic people, especially females, their education level in a lot of countries stopped around the 5th grade, 8th grade if they were really lucky and from good families. So how would I make sure that she got those written directions in a way that she would understand on a daily, you know, on a daily. If we're talking about pills and she's got to take them breakfast, lunch, and dinner, and after food or whatever, I might have a picture of her pill next to, like, a sunrise or her breakfast meal, something that she knows she can coordinate when she's supposed to take it and which pill she's supposed to take when. Because when we're looking at complicated medical directions in a written language, whether it's English or Spanish or Vietnamese, it doesn't matter. If you do not have that base education in your home language, I could write anything you want, but that doesn't mean they're going to understand it. So I would be questioning, what her home country is and how big of her literacy level does she have?
It's funny you say that, Rebecca. My grandmother doesn't speak English. She's Italian speaking only and often struggles with this the handouts they give her because they're so advanced or they're different than her dialect. But you said something that caught my attention, which said when you speak to a Spanish speaking patient, you will listen to see what kind of Spanish they speak. And I'm not a Spanish speaker, but I'm curious to say, why is that a part of your process?
So in Mexico alone, they've tagged 63 known dialects. Some of those dialects are so ancient that they are more of the native language than they are Spanish. But I grew up in Texas, so I can identify a lot of those, what we would call Metzio, mixed languages. So if you think about it, I've got 63 dialects in Mexico alone. There's about 4 or 5 in Southwest United States. Plus there's 2 dialects in Puerto Rico. I don't know how many are in Cuba. Miami, Florida International University has just identified another dialect that is growing out of Miami because of all the mixed Spanish that's there. And so, you think about all these different countries and all their dialects, and it's really about communication. I've had someone tell me, well, she speaks Spanish and I speak Spanish. And I've heard her speak Spanish to this lady, and my client has a complete blank look on her face. I would probably identify the hospital person speaking a dialect from Puerto Rico, and my client spoke from Honduras. And I literally had to translate the Spanish for them. They just, it's a little bit of your dialect, and it's a little bit again about your education level.
Okay, well, these complexities were very, very, very important pieces of information. What I'm taking for that is when I'm providing patient with translation services, or I'm providing them with public health education services. Every Spanish is not necessarily equal, and I should keep in mind what their cultural linguistic needs are. Thank you so much for that. Next, please. And we did do this, so next slide. Yes, so the next thing the CHW does is does a health check. And the reason that this is my recommendation is because we're looking at a patient that had a couple of reads of bad blood pressure in the in the clinic. Now, she has a pre-existing diagnosis, and we know she has hypertension. But for many patients, that initial diagnosis, you want to get a home read some way, and this is the best way to get it, is to get it at the patient's house. I would recommend doing that not the very beginning of the visit, because sometimes the patient's blood pressure will be elevated, just the excitement of the visit and so forth. Do medication reconciliation first, then consider it doing after that. Keep the blood pressure where it is at the patient's baseline. It gives you a more accurate perspective of what blood pressure the patient's living at. So speaking of levels that we're living at, this patient has type 2 diabetes. So we're going to do a blood sugar check too. So CHW performs the health check. Here's what we get. Jamoke, here are your vitals. You know what's on the page. What comes to mind first for you?
She's still hypertensive, even at home. So if she's taking her medication correctly, because it's not working. And her blood glucose levels is also elevated.
Yeah, that's high. Both of those are pretty alarming. Her heart rate's also high too, but it's not triggering anything clinical for me right now. Wendy, do you have something to add?
Yes, I would want to visually inspect her ankles and her feet to check for swelling, because with this hypertension level, she may be having some heart failure going on. And
very good. Very good.
We
got more to say.
We just really want to check to make sure that that's not the case, because it may be such a thing that she needs to take a little more diuretic. It may be a case that she needs to be hospitalized and for observation. These are so complicated, such complicated cases. But I am very familiar with the swelling, and it can be very severe.
And I would encourage you to continue to use that as an anchor. I think that's an exceptional anchor for the quality of the patient's cardiovascular system in general. Why that's important is going to be different for each patient, but in this case, you correctly identified that this patient is at risk for congestive heart failure. And very often, if these patients don't have CHF, they are transitioning towards it. And new diagnosis is a common thing at this stage of the patient's medical history. And keeping an eye out for that initial swelling, or if the patient has an existing diagnosis, being able to see how bad it is and if how it compares to how the patient typically is, it tells you a lot. And if the patient is taking diuretics, which in this case she is, it tells you a lot about her medication compliance. So 100% Wendy, thank you for the insight. And I'd encourage you all to use that method as well if your CHW is in the field. To give a quick clinical overview of things that are popping up for me here, though, I have a lot of trust in this hypertension diagnosis. I do not believe the patient is taking their medication appropriately based on what I've said and seen. And her blood glucose of 180 have, for me, major concerns about her dietary intake and management of her diabetes from a nutritional perspective. Next slide, please. And we did that. I'm getting ahead of myself today. Next slide, please. These are reminders if I forget a question. Okay, so let's do a home safety check, and I'm going to go over this quickly so we can get it all in. Mrs. Tiller's CHW next begins her home safety check. She walks through the patient's home, checking her heating and cooling, her carbon monoxide, smoke detectors, assesses social isolation through an interview with the patient, food security, and accessibility needs. Basically all the things Wendy told us she wanted to do, what she wanted to do 5 slides ago. And so here's what we find. Here are the positive findings here. 1, Mrs. Tiller lives in a tidy 1-bedroom apartment, and I'll say hands if you want to join at this point, folks. Mrs. Tiller lives in a tidy 1-bedroom apartment by herself. She's visited by neighbors twice a week, and her daughter and son once a month on average. She's active in several social groups with friends and neighbors. There is stale and spoiled food throughout her kitchen. No food or fruit or vegetables are present. Next slide, please. Her apartment is tidy but cluttered with belongings. Her home includes several pieces of furniture which are insecure and may fall by your assessment. And there are several electrical cords, floor transitions, one type of panel to another, one type of flooring to another, like a lip, and carpet she may trip on. She's afraid of falling while navigating in her home. She has stated this and states it again this day. All of her carbon monoxide detectors, everything, batteries are dead. God knows when they were functioning. Her bathroom's small and crowded without any disability or accessibility features. There's exposed wires on the 6-step staircase leading to her apartment, and there are no steps to her home. So, I would ask everyone to put their patient safety hat on. What's your priority? Jamoke, we will start with you, and we'll take the hands as well. What's your priority after these 2 slides?
The
patient condition and connect it to a patient condition if you can.
Okay. I would say definitely the unsecured furniture and the flooring, due to her hypertension or even her diabetes. She could get dizzy and fall very easily. If she tried to reach out to steady herself on furniture and that falls, that can increase her injury. And the fact that everything is cluttered and there's no free space, if she falls and lands on something, that could also further injure her.
Mm-hmm. You know, I'm thinking of this this patient's house, and I'm thinking of her cabinet of neatly arranged bottles. My guess is if you look back a couple of rows, you'd find stuff that isn't even on the market anymore.
Yeah.
She saves everything. There's just a lot of folks like that. And I will say, my grandmother's generation, they save everything. They went through tough times. That is a survival skill that a lot of people have adapted. And in addition to giving you a newspaper from the day the Challenger blew up, Mrs. Tiller may be able to provide you with medication that has long since expired. And that is an independent safety concern. The medication, not the newspaper. The newspaper sounds lovely. So absolutely 100%. I'll say hands or Fide, if you could put your, Wendy, what comes to mind for you?
I'm very, very concerned about the woman living by herself any longer. It seems like she has overlooked many, many safety features in her home, maybe not deliberately, but the lady is confused and she has so many comorbidities. I really do think that it's time we had a talk with family members about getting someone to stay with her on a daily basis.
100%. Before medical school, I was a EMT and paramedic, and I spent a lot of time in patients' houses doing 911 responses and patient moves. And let me tell you how many times I brought a patient back, looked at their house, and just said, "This is unrealistic. This isn't going to work. This is a injury waiting to happen." Rebecca, do you have thoughts for us?
Yeah, so there's multiple things that can be done quickly in the interim, because at this point she probably does not need to be living by herself, whether that is to go into an assisted living facility or move in with family. She does need more help than she's getting right now. But in the interim, one of the first things I would do is call the apartment complex, because they have a responsibility to fix a lot of those things, including putting in new batteries. And, again, they can't fix it if they don't know that it's busted. So, that would be my first call, and cleaning the kitchen and maybe calling Meals on Wheels, because that would be another person that would check in with her weekly, deliver healthy foods, talk to her and make sure she's doing these. And these are just interim things. And one of the things that I've realized, and it may just be because we are in a small community, is that a lot of the clients that I serve are very happy to pay it forward. We are grant funded, so we don't charge anything. And it kind of makes certain people feel bad because they feel like they should contribute. I'm sure that I would be able to pull up an ex-client or something and say, could you help me this afternoon? We are cleaning this elderly woman's kitchen or whatever. But I've never, and Wendy has had the same thing where we have clients that always want to pay it forward. And so getting her a quick cleanup, getting her immediate apartment needs taken care of, finding her a food delivery service to make sure she's getting some healthy meals, and again, another person to check in on her, would be a quick fix, and an interim solution for something long-term.
I think that is a lovely point for us to end on. And what I'd like to encapsulate it as is kindness and service spread, and they spread and they pay forward. So I think that's a lesson that all of us can bring back to our practice, both at home and in the clinic. Fide, thank you, and I will mute myself and hand it to you.
Thank you so much. This was such a great conversation. I feel like even me, in my public health career, like I have learned so much from the approaches that you guys take as CHWs. And I hope it's also the same for some of the participants that we have here as well. But anyway, so we have come to the end of the session. If you have any questions, you can always follow up with us via email. And please complete our post-evaluation survey. Again, your feedback is always welcome. Please visit our website at nchph.org to access our latest publications, webinars, and any other announcements that we may have about our learning collaboratives. And we will see you next session on the 1st, April 1st at 1 p.m. Eastern Daytime, and we look forward to seeing you all next week. All right, and have a good rest of your day. Thank you so much. Bye-bye. You're
Bye.
welcome, Mary. See you next time.